joining in. Greetings, everybody. I'm State Representative Karen Camper. I serve as the president of National Organization of Black Elected Legislative Women, or as I love to call, Nobel Women. For those of you who are new to our organization or may not be familiar with us, I'd just like to just tell you a little bit more about us. We are a nonprofit, nonpartisan organization, primarily composed of current and former Black women legislators, as well as appointed officials. Our mission is to increase and promote the presence of Black women in government. Our objectives are to create programs and platforms that advance Black women in the fields of public policy, public service, and civic engagement, to act as a network and support system for Black women in public policy and organizational leadership, to serve as a venue for thoughtful dialogue on issues of public interest between elected officials and stakeholders, and to train and educate a class of cultivated and experienced Black women to assume both governmental and corporate leadership roles. On behalf of our National Board of Directors and our partner, Compassionate Choices, I want to welcome you to the event tonight titled Education, Empowerment, and Advocacy at the End of Life. The COVID-19 pandemic has been a time full of uncertainty. Disparities around chronic disease and healthcare coverage in the Black community has also been complicated due to the pandemic. Because of this, we will aim to discuss how COVID-19 has made the need for end-of-life planning events more imperative. Our partners from Compassionate Choices will address advanced directives, disparities in healthcare, and end-of-life advocacy. Before we begin, I want to thank our partner for working with us on this event. Compassionate Choices is one of our new members to our Corporate Advisory Council, but they have been a long-time sponsor and supporter of Nobel Women. Donna and Compassionate Choices have been an amazing partner, and we look forward to the collaboration even more in the future. We are also looking forward to working with Dr. Sonia Richmond with Vitus Healthcare as well. So I'll start by make a couple of introductions of our speakers tonight, and then we'll get into our conversation. Donna Smith is a diversity and inclusion advisor at and state director for Compassionate Choices in Maryland and DC. She is an experienced professional with over 20 years of management experience in strategic communications, outreach, program management, and legislative advocacy. Prior to joining Compassionate Choices, she served as a policy chief and communications director for the Maryland Department of Aging. In this capacity, she was detailed to work on the White House Conference on Aging as a policy and operations outreach specialist. In 2019, she received a diversity, equity, and inclusion certificate from the Schaefer School of Public Policy, University of Baltimore. Ms. Smith has a bachelor's degree from Tuskegee University and a Juris Doctorate from George Washington University Law School. Dr. Sonia Richmond has been a certified board internist and hospice medical director for more than 15 years. In that time, she has worked in roles across internal medicine and hospice care, as well as in subacute rehab centers and assisted living facilities as a medical director. These different roles have also allowed her to understand the many perspectives when it comes to providing the highest quality care, especially end-of-life care. Both as a doctor and in her personal life, Dr. Richmond has a passion for people and leads with her heart. She understands that medicine isn't one size fits all and works incredibly hard to meet the needs of all of her patients. In addition to her medical career, Dr. Richmond is a certified yoga instructor and has been practicing yoga and wellness for over 15 years. She offers a variety of online yoga and wellness classes for everyone from beginners to experienced yogis. Her yoga and wellness practice has given Dr. Richmond a unique outlook on the medical care she provides, as well as allowing her to offer additional resources to her patients. She is passionate about fusing her extensive knowledge of the two subjects to be informed in her practice, and is encouraged and empowered daily to discover new ways to express love through medicine and yoga. Now I will turn it over to Donna so that she can start our conversation.
Well, good evening, Nobel women and partners. I want to thank you for joining us here today. And I would be remiss if I did not acknowledge the co-chair of the Nobel Corporate Advisory Board, Miss Yolanda Cash Jackson. Thank you, Yolanda, for joining us today. Crystal, could you begin the presentation? So, as I come and talk to you guys every year, I want to talk about education, empowerment, and advocacy at the end of life, and why this is so important, especially now, given the disparities that COVID has once again underscored. Next slide. Life is meaningful because it is a story. And in stories, endings matter. That's from the book Being Immortal. Next slide. I represent Compassion and Choices, and it is the oldest nonprofit that deals with end-of-life issues. We strive to improve care, expand options, and empower everyone to chart their own end-of-life journey. Let's skip this. She already did my intro. So I have a part of the webinar, and Dr. Richmond has a part of the webinar that she focuses on. In this particular presentation, we're going to talk about the goals, rather, of this webinar is to educate on all end-of-life options and the barriers that exist in marginalized communities. Empower people to be their own best healthcare advocates by sharing resources, and encourage people armed with the knowledge of end-of-life options to advocate on their behalf. Next slide. COVID-19, as I stated, highlights disparities at the end of life. We already knew they existed, but they highlighted them this year for us in ways that maybe some of us weren't aware of. And it underscores the need for advanced care planning. Next slide. So some of the disparities. Clearly, African Americans were hospitalized at rates 2.8 times that of white patients in some cases. African Americans died at a rate of 1.9 times the rate of others, of white Americans. African Americans were more likely to have underlying health conditions such as diabetes, high blood pressure, which increased the likelihood of severe illness and complications with COVID-19. We are also more likely to work on the front line or be essential workers who could not work from home. We were also more likely to live in multi-generational homes in crowded conditions. And we were more likely to have limited access to healthcare. In 2017, a study indicated that 10% of African Americans had no health insurance. What are the results of these disparities? We're far less likely to complete advanced healthcare directives. We are far more likely to be undertreated for our pain. We are more likely to receive unnecessary invasive medical procedures. Next. What are some of the reasons for disparities in end-of-life care? The lack of knowledge about hospice or the cultural attitude about hospice. A lot of people in our community feel that hospice is a place you go to die and give up, as opposed to a service you can receive in your home. There are spiritual beliefs that sometimes interfere and can be a cause for some disparities. There's less trust of the healthcare system. I'm a graduate of Tuskegee University, and I'm sure we are all aware of the Tuskegee experiment, but there are a lot of examples of the healthcare system taking advantage of our community. And I'd like to see raise your hand if you ever heard of the term night doctor. I can't see anybody. Is anybody raising their hand? No.
Oh,
Okay. Ms. Coleman, did you ever hear the term night doctor?
no,
Okay. Go ahead.
no, hadn't
Oh.
heard of.
Go ahead. Tell us what you heard of.
No, I have not heard of it. I'm looking forward to hear what you got to say. Tell me about it.
Oh, okay. I'm sorry. So the term night doctor really started being used right around the Civil War era, right before it and right after it. It was commonplace for African Americans to experience doctors coming in the middle of the night to treat their sick. And in some cases, the patient died or was still very sick and they were taken away. And people never saw their loved one again. Some of these patients were taken to medical schools and their bodies were experimented on and helped to teach medical students. Some of these patients were experimented on and died at the hands of the doctors. If you look up night doctors, you will also find that in Baltimore and Johns Hopkins, when you heard of the Henrietta Lacks case, the family initially thought night doctors from Johns Hopkins, and that happened in the 1940s. They originally thought night doctors had come and taken her. Now, that was not the case, but it just shows you how prevalent this mistrust was. And when I did some research behind this, I asked my mother, who's born in 1942, had she ever heard of night doctors? And she said that she remembered growing up that when the kids were misbehaving, her mother, my grandmother, would say, y'all better act right or the night doctors are going to come get you. And so while she didn't know the story behind it, that mistrust and that fear was passed on from generations.
Okay.
So that's how some of this gets spread in our community, and rightfully so. There are negative attitudes toward hospice. There are poor communications with medical providers. And we're not comfortable discussing death. A lot of us are fighting to survive. So talking about death is not something we're comfortable with. But just like there are healthcare disparities in life, there are disparities at the end of life. And we got to learn to live better, but we have to die better as well. And then there's a lack of cultural competency by medical providers. Some of this, Dr. Richmond will go over in detail, but I just wanted to paint the picture of the diverse reasons for healthcare disparities in our community. So before I move on to advanced care planning, any comments or questions about that first part? Okay. So now let's talk a little bit about advanced care planning. Next slide. Advanced care planning, of course, is making decisions about the health care you would want to receive if you're facing a medical crisis. These decisions are your decisions, and they're to be made based on your personal values, preferences, and your discussions with your loved ones. But before you can discuss these things with your loved ones, you can go into the next one, Crystal, I'm sorry. You have to decide what your value system is around the end of life. You need to decide what type of treatment you would or would not want should you be diagnosed with a life-limiting illness, right? Do you value quality of life over quantity of life, or vice versa? You really need to do a gut check to see what's important to you. And once you understand that, you need to record that and share your values with your loved ones so they understand what it is you want if you're incapacitated. So completing advanced directives and putting them in writing that would tell them what type of treatment you would or would not want, and who you choose to speak for you should you be unable to speak for yourself. If you're in a coma, if you have dementia, these things are very important. Now, I'm going to share a personal story at this point because this became relevant in my life when I lost my father at a young age. I had just graduated from college and I was a daddy's girl and I clung to him. And when I lost him, I was lost. And I clung to my mother. And about 10 years after he died, we lost him to a stroke. It was sudden. We weren't prepared. But about 10 years later, I was telling my mother that I loved her so much that as long as the hospital paid the electricity bill, she would be somewhere hooked up to some machine. She would be alive and I would be in there visiting her. Because of course, to me, that sounded good, right? Because who was I thinking about? Me and what I wanted. And my mother, who is a saint, and she is everything in her church but Jesus Christ, on the deacon board and so and so and so and so, almost cursed me out. She said, Donna, when it's time for me to go, you better let me go. If God tells me it's time to go, who are you to try to keep me here? It was the first end-of-life discussion I had ever had with my mother. I was shocked. I said, Mama, you mean you don't want to be with me as long as I want to be with you? She said, absolutely not. Now, I say that half jokingly, but in all seriousness, had something happened to my mother, I would have done exactly that, because I was thinking, well, I just lost my father. I don't want to lose my mother. She has to be here. I was thinking of me. I was not thinking about her. And so I would not have been a very good advocate on her behalf. But on the other hand, she hadn't told me what she wanted. As a result of that discussion, I am now her healthcare proxy, and you better believe I will fight for what Shirley Smith wants. And we have discussed it, and we have a plan, and it is recorded, and we have discussed it with her other two children who are my brothers, and we're clear about the path we need to take should something happen to her. But we got there by coincidence. And I want to help people avoid being in the place where they, number one, don't have a plan, or number two, don't have the right healthcare advocate. Just because someone loves you does not mean they're the best healthcare proxy. You need someone that's going to do exactly what you want them to do, not what they want to do. Next slide. So what's the benefit of this advanced care planning? Your goals, your values, and priorities will guide your medical decisions, not someone else's. If you don't make these decisions for yourself, potentially someone who does not know you and does not love you will make them for you. And families will experience less distress and conflict because they're not trying to figure out what you would want. They're not acting in their own best interest, hopefully. They are going along with the instructions you provided them. Any questions or comments about this section? Anybody?
I have a question.
Yes, ma'am.
The advanced directive, most people don't seem to get that until they're faced with in a situation where they have to make that choice. So that makes it more difficult when you're in it and you're trying to decide what the directive is. So what would you recommend as a time frame to begin or to fill out or to have your advanced directive done before you actually there and they're saying, okay, sign here, what do you think? What do you know? It's kind of,
Yeah.
Great question. Great question.
Great question.
Dr. Richmond, I see you.
Great question.
You experienced
Karen,
that.
I'm like, Karen, I'm on the edge of my seat right now. Donna, I'm sorry. I'll let you answer.
Thank you.
I'm at the edge of my seat.
You are so right. A number of times people wait to have these very hard discussions in the emergency room. That's the worst place to make decisions about your advanced care planning, right? It's called advanced planning because we want you to do it in advance of your emergency. So some of the best times to do it, and I'll let Dr. Richmond add in as well, but some of the best times is, when the family is gathered, when all are in their right minds and in good spirits, and you can have a clear conversation with people and pass it around to your loved ones and let them know who is your healthcare advocate. The best time is to have it in a non-emergency situation. And then it's not a one and done document, right? Because, for example, my healthcare proxy right now is my best friend, Marcia. Well, in 10 years, what if Marcia and I are no longer best friends? Maybe she's not the best one to speak on behalf of me. And so as your life changes and evolves and your situations change and evolve, you should change your advanced healthcare directive. You should look at it every 6 months to make sure it still reflects your values and priorities. Because what you wanted at 25 may not be what you wanted at 45 or 65. And you can change these directives as much as you want to. But when you change them, make sure they are given to the right people. They have the updates. That's very important. And I also want to say that every state has its own healthcare directives. 50 Wishes is one that is common and can be used in most states, but every state has their own version as well. So I live in Maryland. I can't use my Maryland advanced healthcare directive in DC. If I move there, I would need to get one that is from DC. But go ahead, Dr. Richmond. Did you want to address this question?
No, Donna, I think you covered it very well. The conversation itself should happen at a time and a moment where we're not surrounded by stress. The external contributors, when you are dealing with something so sensitive and so intimate, can really play a major role in guiding you as to what decision you make. So having these conversations early on, when everyone is on what I would say the same level, and you can expand with the conversation, because it's very detailed in regards to life or death, or do you want resuscitation or not resuscitation? There's different levels to it. And so this is where we come from, the informed perspective, in knowing that you have the ability to be as specific and detailed as you want to be. And when is the best time to do that? Early on, when you're not surrounded by hospital clinicians, administrative people who unfortunately has a goal in mind of triaging and getting you transferred to the next level of care. I would say that oftentimes there are a lot of questions that come about when you're having this conversation. And the best place to have it is in a place where you consider home, where you consider supported, where you're considered loved. So it's getting to know that advanced directive, getting to know your loved ones, because you may discover certain things about the people that you've grown up with your whole entire life, and their perspective on resuscitative measures can be glaringly different from what you may have assumed it was. And we want to honor that all the way through.
Thank you. I appreciate that answer. In the way you described it, it's almost like how we're always encouraged to have a will. And so you can always update the will, you can change it as time go on. So an advanced directive can kind of be a similarly approach, where as things change, you change and update it. That's good to know.
Yes.
Quick story with this weekend, Mother's Day. We're at my niece's thing, and I'm comfortable. My mother and I are comfortable about talking about end of life. And we were talking about, what she wanted at her services and stuff like that. She makes me write everything down. So I wish I had a thought about this while I was there, though, because we had 4 generations there, and everybody was comfortable talking about it, even though it was a Mother's Day event, but family was gathered, and we had a chance to talk. So I'll make sure I take care of this with the quickness. Thank you for that. I appreciate it.
Thank you.
Yeah.
Next slide, Crystal. So these are examples of planning documents. A living will is an advanced healthcare planning document. Advanced healthcare directive is a advanced care planning document. And then there are addendas. If you live in a senior facility, there might be addendas there about dementia and other things that you want to make sure that are included. Next slide. So I'm going to, we're having such a good conversation. I want to make sure I give time for Dr. Richmond to speak. I'm going to gloss over this quickly, but you have this presentation and it has some helpful information in it about dementia. But with dementia, the final chapter is from another's book. You can't imagine the impact of dementia until you experienced it with the one you love the most. And we are finding that one of the stats is that African American males get this at a 2-to-1 ratio of white males. And so this is something that is very prevalent in our community. And so knowing some things about it and preparing for it to the extent you can is important. Next slide. Dementia is a collective term used to describe various symptoms or cognitive decline, which result in a loss of mental capacity. It is a symptom of several underlying diseases and brain disorders. It's not a single disease itself, but in a general term given to describe symptoms of impairment in memory, communication, personality, and judgment, which ultimately impair function. Next slide. It's also called a neurocognitive disorder. Alzheimer's disease is the most common cause. Between 60 to 80% of people with dementia have Alzheimer's. But there are many as 50 other causes of dementia. Dementia can improve with treatment. Many of the diseases that cause dementia, however, aren't curable. Next slide. This gives you some stats. It's predicted by 2030, 50 million people worldwide had it in 2017. It's predicted that 82 will have it in 2030, 152 by 2050. In the US, 5.7 million have it. 60 to 70% of it, though, is from Alzheimer's. And it's predicted that by 2050, 13.8 million people in the US will suffer from it. About 5 to 8% of adults over age 65 have some form of dementia. This percentage doubles every 5 years after 65. And then 50% of individuals in their 80s have some measurable dementia. Next slide. So we talked about the types. Alzheimer's is vascular. This goes into the various types. Now, mild cognitive impairment is not dementia. And this is function versus dysfunction, but it might lead to dementia. Next. Dementia symptoms and behavior problems will progress over time. Health team and caregivers might try the following. Enhance communication. If you're dealing with a dementia patient, you need to speak very slowly. Use hearing aids. Simple vocabulary, one idea at a time, and cues and gestures. Encourage exercise, improve balance. Cardiovascular health, strengthening may decrease depression, and it might slow the disease down a little. Engage in activities that are enjoyable for the patient, and establish rituals. And this is another case where advanced directives really make a difference. If you have dementia prevalent in your family, you might want to look at your advanced directives and putting in a dementia prevention, how you want to be treated if you are incapacitated with dementia. Next slide. Options at the end of life. Let me see how I'm doing. I got 5 minutes. Okay. Options at the end of life. What are your options at the end of life? Healthcare directives, we discussed. Pursuing life-sustaining treatment. You can go in the hospital, and like I told my mom, you can get every life-sustaining treatment they have. That is totally okay if that is what you want. Next. But you can also refuse or discontinue treatment, right? That's with the post or most form, medical orders of life-sustaining treatment, or physician orders of life-sustaining treatment. And I'll let Dr. Richmond address that. Next, hospice. She's going to talk to you in detail about hospice. We are so pleased to be partnering with VITAS in this presentation to you. Next, you also can stop eating and drinking voluntarily. That is allowed in all 50 states. Next. And continuous deep sedation or palliative sedation. It is what happens sometimes in hospice when the intent is to make you comfortable. They will give you a high dose of medication to make you comfortable. Next slide. COVID-19 and dementia. Several studies have shown that people with dementia are at high risk of developing severe COVID-19. The study suggests that this high risk may not simply be due to the effects of dementia, advanced age, or frailty, or exposure to the virus in care homes. The effect could be partly due to an underlying genetic change, which puts them at risk for both COVID-19 and dementia. We're learning more and more about COVID every day. Tools and resources. So one of the things I think I have sent this, I shared this at various conferences, and this is the physical book that we hand out at our table, but we have it electronically. This is the End of Life Decisions Guide. This guide helps you to think through your priorities for care at the end of life. It includes information on advanced healthcare directives, do not resuscitate orders, and several addendums like the dementia provision we spoke of. Next slide. Now, these are some of our toolkits, but one of the ones I want to share with you, and this is on our website, is the diagnosis decoder. Oh, I hit it, Crystal, like I was in charge. Could you hit the diagnosis decoder button? Double click on it. I don't know why it's like. Did you double click on it? I'm sorry. I don't know what's going on.
Yes, it took me to the website. Is there another part of it that you want us to get to?
No, you can just go back to it.
Okay.
Not to the website, just to that page. I'm sorry. This diagnosis decoder, if you click on it, it will take you to a page where you can put in your chronic disease, and it will and you can put in other aspects of it, you know, like what you value. And it will suggest questions for you to ask your doctor. You know, gone are the days where you have the same doctor all of your life, right? You have about 10 to 15 minutes with your doctor. And sometimes when you get diagnosed, you don't know what to ask. If you put in information about your diagnosis, this diagnosis decoder will suggest to you questions that you can ask your doctor when you go in for the visit. We have other value and priority tools. Some of them are for dementia. And then we have some other tools like using telehealth, advanced care planning, dying in the age of the pandemic, and how to plan your care resources. Next. All of these can be found at compassionatechoices.org in the life planning. Next. How can you help? We certainly want you to share this information and resources with your constituents. Next. Connect us with groups or organizations that would like a speaker to give a presentation on this topic. And this is my information where you can call me directly, or you can call Wendy Miner, my campaign coordinator, for more information. Any quick questions or comments as Dr. Richmond gets set up? Oh, as she's getting set up, I believe I sent to everyone an article. I found this to be a very interesting article about stress and disparities at the end of life. I really would suggest that you read it. It indicates just dealing with the stress of biases and racism in America can cause you to have poorer healthcare outcomes, even if you don't have diabetes, even if you don't have some of the other underlying conditions. But dealing with the stress as a person of color in the United States adds to poor health outcomes. It's very interesting reading, and especially talks about how it affects African-American men. And so I shared that in the chat. With that, I will turn it over to Dr. Richmond.
Okay, Donna, before you go, thank you for the information. And you know, I truly understand that as people, we do not have those directives. What would you say is the best time for people to get one? You know, we have wheels, but we do not have directives. I think a lot of time people don't. I guess it just don't even click on us that we may end up going to the emergency room and may not come back home or whatever. So what do you think, or when do you think would be the best time for a person to look at getting an advanced directive? Around what age? What age are we talking about? Or is it an age at all?
For me, I have a 19-year-old son, and because I'm in this business, I had him sit with me while I filled out mine. And once he turned 18, I made him fill out his, because old people aren't the only ones dying, right? And you need to fill it out and look at it every 6 months. Because you do it in advance of a crisis or a healthcare emergency. And it really makes you focus on what's important to you. So there is no wrong time, there is no right time, but preferably you should do it. I encourage 18-year-olds and over. You know why? Because we have to show and model for them how they need to prepare for their end of life. It's inevitable. We prepare for weddings and funerals and divorces and vacations. Other than being born and your children being born, this is probably the most important aspect of your life, and it happens to all of us. And in our community, it hurts us when we don't have these end of life discussions. I remember really quickly I remember going to the family get-togethers, and I had this aunt that I loved, but she always fell asleep at the get-togethers, you know. And I would say, "What's wrong with Auntie Doris?" And my other aunts and uncles, they would say, "Well, you know, Auntie Doris, she got that itis." I never knew what itis was until 30 years later. I was pregnant with my child, and I had diabetes, and I realized itis was diabetes, and it was prevalent in my family, but no one told me about it. We didn't talk about it. Maybe had we talked about it, I could have avoided it. And so having these discussions, filling out these forms, it really helps our families. It models for our children how they should get their plans together.
Looks like Representative Schofield has her hand up.
Yes, ma'am. You're
Donna,
on.
I just want to thank you as well, and to echo what my colleague, Representative Scott, said. In my household, my daughter, when she moved, when she went to college, I had them. But more so, I was concerned when she moved to New York for a minute. And I told her, I mean, if something should happen to you in that state, I can get to you, but I may not be able to get answers that I need and decisions that need to be made. So therefore, that was something that we put together in the package before she left. She kept a copy, I kept a copy, and then vice versa, because it's, you know, I'm not married, it's just she and I. I needed her to be able to have responsibility, so that if she's in New York, I'm here in Georgia. If something happens to me in my healthcare, she has to be the one to make decisions. And I had to have that paperwork filled out. So I think it's a conversation that is just part of responsibility of being an adult and a parent. Recently, my brother, and I've been talking to my family for years about this. They don't want to hear it. They don't want to talk about it. But my brother got COVID in the beginning of the year, and we didn't know about it. And so so then it came to a point where he got really sick. He was in the house and he couldn't even move. He couldn't walk or anything. Later, after he you know, fully recovered, I said to him, "Do you understand why it's important that you have a health directive? I can't even get into your apartment because my name is not on your lease. So you would have laid there and didn't have to, and died and didn't have to, simply because you refused to fill out a form that gives somebody the power to make a decision for you. Not to mention, if there's nothing in writing, then, you know, all of the headaches and everything that it goes to trying to figure out and sort out mess. To me, I have the conversation all the time. My family gets mad, but I'm like, that's irresponsible. When you have the ability while you're living to express your wishes, and you make a conscious choice not to do it, to put that grief on somebody else is irresponsible."
Yes, ma'am. Yes, ma'am.
And
Thank you so
look
much.
like Representative Aird had her hand up. Is your hand still up? I thought I saw another hand. Okay, maybe
No,
not.
I'm okay. Thank you.
Okay, all right, cool beans. Okay, Dr. Richmond.
Yay. Hi, everyone. Good evening. Thank you again for presenting us with this platform, Nobel Women, to speak about education, empowerment, and advocacy at the end of life. The purpose of my portion of the presentation is to focus on what VITAS has to offer in the form of education in the setting of hospice care. And the assumption is that hospice, the word hospice, the premise behind hospice, what it means and how it affects us on a day-to-day basis, is not explored or expanded upon in a way that we can comfortably speak about it amongst our family, amongst our friends, and also helping us to advocate for ourselves, for the people that we love so passionately, especially at the end of life. So our VITAS, our national story. Nick Westfall, Mr. Nick Westfall is our CEO with headquarters in Miami, Florida. We have over 11,000 employees, 5,000 volunteers, and we were founded in 1978. And we have a map accompanying here showing that we bring our services nationwide. But what's most important is that we pay attention to the pulse of what's going on in the world, in the nation. And when the pandemic hit, no one could have expected the degree and the depth at which it affected each and every household and everyone's lives. We changed our perspective, we refocused, and we set out and created the message informing that COVID-19 itself is something that's very important. And unfortunately, many people were succumbing, they were passing away. And this too presented opportunities for us to provide that umbrella of support in the setting of end of life, of education, in an interdisciplinary approach, so that family members felt supported. They felt the advocacy from the standpoint of psychosocial support in exploring and expanding the advanced directives, from the standpoint of transitioning from the hospital to a place where these patients would call home to pass away peacefully, surrounded by people that they love. In the setting from a clinical perspective, having the physician, nurse practitioner, and nurse case manager to care for these patients from the perspective of administration of medications and education on disease, and also our hospice aides and volunteers to help guide, hold hands, provide care needs that are very important. By creating this umbrella and creating this approach and this advocacy for COVID-19 and incorporating it in our efforts to bring the message for hospice care, it has expanded everyone's knowledge that we come in contact with. And it's very important to show the benefits of having these conversations of hospice early on, having the conversations of advanced care planning early on. And I would say, and my goal is to weave, some pearls and aspects as we go. The question was, when do we introduce or have the conversation about advanced care planning, advanced directives? I say now. I say today. I say tomorrow, pick up the phone and reach out to your provider, look online with the resources that we are providing here, and pull that information down and educate not only yourselves, but other family members in getting these documents in place. COVID-19 is still with us in many aspects. We're still affected by it. And so we now have an opportunity to make a difference. Our goal is to build that awareness, to look at the low utilization of end-of-life care resources within our underserved communities, impact these cultural differences, and educate amongst everyone so that everyone's on the same playing field, so that everyone is exposed to the same type of information, the same type of resources, and knowing that it's not, as it's stated in my bio, it's not a one size fits all. But the more you know, the more you feel empowered to make important decisions like end of life. So we're looking at the hospice utilization, the trends that we have come to know very commonly here in our organization. We're looking at the utilization specifically in our minority communities, the cultural differences and its overall impact on end-of-life care decisions, the end-of-life process, identify the impact of hospice education deficits, and establish next steps for outreach to VITAS corporate team. So here are the trajectories of dying or passing away. And so looking at each and every graph here, starting in the top left corner as you face the screen, patients are high functioning, as you can see along that y-axis, the long column here. They're high functioning, and then there's an abrupt change, and unfortunately they pass away. So this is creating a square. They're going along fine, natural trajectory, or living their lives, and there's an unfortunate event. And one example that I can give you is if someone has a heart attack or a stroke, and this immediately changes their end of life trajectory. It changes and it uproots a lot that has to do with their own personal household, because this particular loved one passed away abruptly. And so you ask the question, what about the advanced directive? What do I do internally in my home? How can I prepare for this sudden part of it? I would say at time 0 is when we start that, because we know that we are all going to pass away at some point. It's which graph is going to look the most like us and our family members. As you go across horizontally, top right corner, some patients have a diagnosis of a terminal illness. Definition of a terminal illness is the unfortunate circumstance is if you were going to pass away within 6 months or less, that this illness itself is impacting your quality of life. Many patients have a terminal illness diagnosis, and then they follow a trajectory of decline. And it may take a path where this terminal illness, there's treatments that are involved, and unfortunately, the symptoms outweigh the benefits. The symptoms take the lead, and this loved one will pass away. An example you may see is if someone has a diagnosis of breast cancer, and initially you may hear from the clinicians, from the treating team, we can use chemo, we can use radiation, we can introduce these different modalities of treatment. And unfortunately, the cancer has a mind of its own and chooses to spread throughout the body, which is something that cancer does. And unfortunately, the symptoms associated with this spread can lead to someone passing away. Looking down at the bottom left corner, we have someone who is moving along in a trajectory, and they're having a lot of peaks, they're having a lot of valleys, but they never necessarily reset back to their normal baseline functioning. Someone who would represent this particular picture for me is someone who has chronic obstructive pulmonary disease, even someone who's suffering from advanced heart disease. Medications are introduced along the way. Interventions are introduced along the way. You find that there's frequency of doctor's visits, frequencies of hospitalizations, frequencies of staying in a rehab facility, and unfortunately takes on an unfortunate progression and decline, and ultimately passing away. And lastly, in the bottom right graph, you have someone whose function itself is already low, whose trajectory of illness over time shows that they are fully dependent on care, dealing with a lot of symptoms, may even increase their health care dependence, like being in a hospital, nursing home, or rehab facility, and they too would pass away. Population that often represents this last graph is someone who suffers from dementia. So when is it time? The same way that we had the conversation about it, when is the time to have this advanced care planning conversation? When is it time to discuss advanced directive? It's now. It's now to explore what is it that hospice actually gives you? And what are some of the common misconceptions that are surrounded by hospice? I can't tell you on a daily basis, I spend more time speaking about the misconceptions that come with hospice as opposed to the benefits of hospice. I think oftentimes hospice equals death, but hospice actually equals treatment. Hospice equals choice. Hospice equals empowerment. Hospice equals putting you first and no longer being guided or driven by the medical interventions that are presented to you. It's choosing the quality of life for your care. So oftentimes patients that I do care for in the community, patients who are referred to us, have a terminal illness. And this is when it's deemed by two treating physicians or two physicians involved in the patient's care that unfortunately this particular illness cannot achieve a cure. This particular illness has advanced beyond the point of providing quality of life with these interventions. This particular illness, unfortunately, would benefit from more quality of care aspects, and unfortunately, the patient more than likely would pass away within 6 months or less. One misconception: hospice means I will die in 6 months. No one has an expiration date. No one can tell you that this is when you will pass away. As a trained physician and clinician and education that I receive on a daily basis at VITAS, we can look for signs and symptoms that can point towards that, but it's not a hard and fast rule. It's saying that me as a clinician would not be surprised if unfortunately you or your loved one would pass away as a result of the illness that you've been diagnosed with. Patient and family must agree to the care plan, the goals. The goal is physical, the goal is psychosocial, emotional, and spiritual. Hospice care is interdisciplinary. It's no longer led by the physician. It's collective and it's led by the patient themselves. So hospice utilization. So we're looking at days of hospice care per patient. And you can see that going all the way down, greater than 180 days spent in hospice care. So that gives us our 6 months span, 14%. So what this pie graph is showing us is that only 14% is really, really benefiting from all that hospice provides. And I can go down the beautiful list of how you can develop and form such a beautiful, supportive relationship receiving hospice care, especially during times of terminal illness. 1 to 7 days tells us that the utilization of hospice is not high at all, that we still have to get on the ground. We still have to have these conversations. We still have to get the literature out. We still have to have these platforms where we discuss in depth what are the barriers that are in place that are keeping the utilization of hospice away from us. More people are spending time using hospice, or actually more people are spending time not receiving hospice when they can clearly benefit from these services. 14% versus 28%. So this number of days, 7 days, is not enough time to really receive and benefit from these beautiful benefits, where you have a social worker walking you through the process of filling out documentation, FMLA paperwork, advocating in the community for you, outreaching and outsourcing, and bringing in a community of help, where you have our chaplain who's non-denominational, having conversations not only with the patient, but with the family. Our first VITAS rule and law and what we stand by is the patient and the family comes first. So we have this interdisciplinary approach, which supports, hugs, and loves the family, but the utilization is not high enough. And so the question is, why is it not being utilized? And here, there's many layers to that. And if you look on the next slide, looking at this chart in a different way, many patients, or the percentage of hospice patients by diagnosis, as you can see, the highest thing on this graph here shows that cancer is far and beyond all of the other diagnoses. But each and every diagnosis on there represent a person, represents a family who loves that person who's suffering from this particular illness. Why has utilization not gone up? I can say it's multifactorial. There's aspects of the patient and their family who have not been educated. And oftentimes we point that out very well in underserved cultures, underserved communities. There's other aspects where the clinician themselves have not been educated because they have not received that information in their training through undergraduate, through medical school, even through residency. And so if you are not seeking this information out, how can it come to you? And this is what we need to do from an outreach perspective, is get the messaging out there so that the utilization can increase, so that this avenue or aspect of healthcare is explored, received with open arms and in a supportive environment. So we're looking at population projections in the minority communities. And what our census is projecting is by 2016, Our minority communities, the Hispanic, Latino Americans, the African American population, as well as Asian American population, will severely increase. These are more people who are using our healthcare system, more people who would benefit from education, more people who unfortunately would be diagnosed with chronic and terminal conditions and would benefit from supportive care. So how can we support, or how can we anticipate these needs? We start the education today. So the census from 2020 for our African American population predicted 44.4 million for our census, 2050, 57 million, and 2060, 86.2 million. That's 86.2 million people, families, caregivers, all of which would fall under the umbrella that would benefit from learning about hospice care, learning about this aspect of healthcare, because it is a type of treatment. So we're looking at continuation of race and ethnicity, but now we're exploring and we're opening this up and looking at it closely through this crystal ball or this magnifying lens. Hospice utilization is low overall, but when you break it down from an ethnicity perspective, you can see that there is a significant difference between our Caucasian human beings using hospice care, well aware of hospice care and its services, versus Black and African, Hispanic, Asian, as well as our Native Americans. 82% versus 8.2%. That means we have a huge margin where we need to fill in the gaps of lack of education, lack of exposure, and ways that we can outreach and provide this support. So our end of life care barriers, they're barriers to everything in life. There are barriers for me being a woman. There's barriers for me being a Black woman. There's barriers for me being a woman whose family emigrated from this country, from South America. There's so many barriers, but a major aspect is the cultural awareness, cultural competency, and the coined term of culturosity. And that's being curious and having the desire to learn about different cultures. The way I communicate and speak to family members is creating an individualized plan of care, individualized type of conversation. My goal as a clinician, as a human being, is to meet each and every person where they are, not to bring them where I am. And this is the first way that we can support everyone. People receive information differently, and we have to adjust. We are the providers of this information. So we adjust in the way that we share this information. We provide the support in ways that this information can be received. And we create an environment that removes and dispels all of the misconceptions that may be out there. And we also understand that there are real barriers out there. We must stay aware culturally. We must be sensitive culturally. And we must educate ourselves and develop a competence in our behavior, in our attitude, in the ways that we create policies to come together and work to effectively bring this information cross-culturally. So in our awareness, and here in our quotations, it says, misunderstandings arise when I use my meanings to make sense of your reality. So in essence, I am projecting my own meanings on you. And that's the first line of creating a division, creating a misunderstanding, and also making that barrier even higher. So being sensitive is recognizing other values and perspectives. There's no way that we can live or walk in anyone else's shoes. But as fellow human beings, as we walk on this earth, I think it's very important that we at least enlighten ourselves to the possibility that these other cultures Other perspectives are very important in the way that we provide information and also in the way that information is received and gathered. So common misinterpretations, lack of awareness, our own culture is not conscious to us, and projected similarities. There is an assumption, I'm a Black woman, I'm speaking to another Black woman, we come from the same walk of life, and that couldn't be any different. DC is divided into 4 corridors of Northwest, Northeast, Southeast, Southwest, and it couldn't be any different, just like a zip code. And so when you walk into someone's life, when you walk into someone's home, there's an energy that's exchanged. There is a moment where you're making or breaking this moment. And I would say, keeping your ears open, keeping your eyes open, and be ready to receive before you start speaking and providing information. Learn where the people and patients and the people that we're caring for, learn where they're coming from and what their perspectives are, and be disarming in your nature before you provide this very, very vital information. So how to help the medical community embrace and celebrate diversity? Let's admit that we just don't know. We remove our judgments, we use empathy. We continually check our assumptions and be comfortable with the ambiguity and celebrating the diversity, celebrating learning, celebrating expanding, celebrating exploring. And this will empower not only us, but it empowers the family members and they feel heard. So in our African American population, topic of death and dying poses many conflicts. I would say, just in my experience and in my own exposure, death isn't discussed until it has happened. But we all know that we will pass away at some point in our lives. And the question is, how do we want it to look for us? And many would want to pass away in their own home. Many would want to pass away the way that they want to pass away. And knowing that there's a treatment out there, there is a journey, there's a path that you can follow where you can determine how that would look for you, especially in the setting when you're told that, unfortunately, your illness is terminal. Unfortunately, we feel that more than likely you would pass away within 6 months or less. The lights turn on, the positioning changes, and you take hold and you have the leadership there and the support of the hospice team, providing the education, providing the guidance. Oftentimes, in death and dying in our African American population, we find that emotions are expressed openly at services, at the funeral services. Attitudes towards cremation can vary, can be very tricky. Attitudes towards autopsy can be very tricky. And the attitudes toward organ donation also can be very tricky. Why is that? It's multifactorial. There are many layers to that. And I say it's because of our pre-existing history, a history that we can't shy away from, that is a reality, that we have experienced exposure of our population, that we have experienced the Tuskegee Project, that we have experienced Henrietta Lacks here in the DC metropolitan Baltimore region at Hopkins. We have experienced many aspects of our life where we've been tested, where we have quote unquote been betrayed. So here it is. Now we're talking about death and dying in a way that is not comfortable for us. How can we talk about organ donation if we haven't healed from our pre-existing history, nor if we haven't explored the cultural differences? So the end of life care barriers, hugely, is education. And studies have shown, this is dating back to 2018, Journal of American Geriatric Society felt that 70% of people are not knowledgeable at all. the best decision you can make is an informed decision. You can elect to receive the type of treatment that you desire, but on a platform where you've received all the information, all the opportunities, all the avenues that you can possibly seek in living the life the way that you want to live it. A very, very small amount, I would say, on this pie graph here, 3 to 8% of people have sort of knowledge about end of life care. So we have a whole big pie graph, whole big chart here that we have opportunities to bring education to. So partnering with community advocates, I think, would help get the word out. Forming this platform, expanding on the services that VITAS already provides, from the clinician standpoint, all the way down to helping families from an advocacy group. So there's disease-specific digital education that we offer, and it helps physicians learn about information where it comes to referring patients, learn about information disease specific. There's peer-to-peer clinical education led by my fellow medical directors. We get online. There's a journal club reading going on right now. The important way to empower ourselves is to keep the education going, to communicate amongst each other, and to grow together. We have our VITAS app and website that's right here at a palm's level to bring that information and to speak about this disease-focused education and awareness. These high quality tools can help create that platform to getting that education out there, to improving the knowledge out there, so that 70%, we flip it, where we have 70% of people who are knowledgeable and 3% who are not, or 100% who are knowledgeable. And so we keep this quality initiatives going. We get on the ground, we expand, we partner, and we bring this information community to community to community. And we keep it all alive, and we empower each other through education. So with VITAS Healthcare, I am so proud to represent our local Program 68, Washington, D.C. I've been with the program now for almost 10 years. My wonderful general manager, our marketing director, our vice president of operations have been so kind to be on this call. My very dear and near friend, Makia Burgess, who is our marketing representative, is on this call. Kate is our advocacy and outreach contact, and she also serves as our general manager. Karen serves as our vice president of operations, visiting our program, visiting all the programs, and keeping that information and knowledge so much at the forefront. And Mr. Howe is in charge of our program for marketing. And we get on our calls every week, every day, and we discuss ways that we can bring this information to the community. Barriers that we have encountered ourselves locally, nationally, and ways that we can continue to expand. So please write this information down. Please do not hesitate to call us, to have us speak in your own communities, because this information is so vital for everyone.
Thank you so much. That was very informative and very enriching. I love the way you presented the information. It was very understandable. We get it. And your passion definitely comes through. So thank you and VITAS for being here tonight. Did any members have any questions for Dr. Richard?
This is Representative Scott again.
Representative Scott.
You know, I am thankful for the information, and I will definitely, I'm sitting here trying to boggle my brains right now of thinking about trying to get my family to get on a Zoom call so they can get this information. I do have doctors, and I know that they have an advanced directive, but The rest of my family, I know is something that they have not thought about. They do not think about, and you know, it just something that we just don't talk about. We don't have that conversation about, but I understand the importance of it. So not only do I would like to have a conversation, you know, with both of my families, but as well as with the people within the district, in my district, because this is something that I do not hear a lot about as I go on my day-to-day stroll around Georgia. It's something that you don't really hear a lot, or something that we do not talk about a lot. So it is something that I will be looking into, and I do have a breakfast for my senior citizens, and I think this would be good for them.
Absolutely.
Definitely would be
Absolutely.
good for them. So, you know, hopefully this year we will be able to have it, and it'll be one of the things that I would be looking forward to. So I don't know if you all do this all over, but I
Yes,
know
we
Zoom,
do,
anything
Representative
is
Scott.
possible. You all have any connections here in the metro Atlanta area, but it is something that I would definitely like to get people
Yes, we do.
involved in.
Very good.
Yes, we do,
Representative Scott.
Representative
Oh, go ahead.
Scott.
Yes, ma'am.
And this, that's very good. I'm sorry. No, I just wanted to echo Representative Scott. Yes, it's very important to bring your family members into this conversation, and please don't hesitate to contact us. Reach out to us, and we are here to speak again to whomever you bring to us to have this very, very important conversation, and also connecting you with our local VITAS program in the Atlanta, Georgia area as well. But we are here. We are.
Thank you. I see Senator Agberry has joined us. She's our board financial secretary. Thanks for being here, Senator. I think Representative Schofield had her hand up, or was that from before?
That was from before. Sorry about that.
Okay. Did you have anything?
No, great information. Thank you.
Okay, very good. I noticed that there's some links put in the chat too that we will keep and send to members, and we are recording this. That we will also post this to our YouTube page and get it out to our members to see those that are not here. You know, you made a statement that many of us want to die in our homes, and so this thought around hospice in our communities is been that you're going to go somewhere.
Yes.
And so in your mind, there's no loved ones coming by, you know, they're you know, I'm not going to see my family, no friends, but if I'm at home, at least people coming by and they're spending time with me. They're not going to come to a place. And so I think we need to share more with people about hospice being available in the home, because most people don't see that. They see it as this is a place I'm going to go. And that's why I think those numbers are so low, where you showed the percentage of people that take advantage of it. In their mind, I'm not gonna go over here somewhere and be by myself with no one that loves me and just people coming in, you know, moving and turning me all day long. But what about my loved ones? And I think that is the missing piece for people. They don't understand that they can have this treatment, this care at home. And so that's the education piece that I think you all could do to help turn the tide on that.
I always say, thank you, Representative Donna, if I may, because Donna pointed that out so beautifully in her presentation. I often say, hospice goes wherever you consider home. And we want you to be with that familiar smell, that blanket, the traffic of home, you know, the door opening and closing, the pets, the food. And so we go where you want to be. And first and foremost, we don't want you in the hospital. You don't want to be in the hospital. But sometimes, unfortunately, the hospital in some ways can, you know, it's your refuge, and you don't know that you have this other treatment option
Yeah.
where that hospital's coming to you, basically, the type of interventions that we provide. Hospice does not mean do not treat. I have personally initiated patients such as IVs in the home, medications via pump in the home. I've personally provided certain treatment options. You're carving out your own plan of care. Hospice does not mean do not treat. What hospice means is you, me, I come first. I am the leading person in the treatment for my care needs. And this umbrella and this beautiful supportive system, interdisciplinary system, is here to support me every step of the way. So now daughters, sons, nieces, nephews can be just that. And we provide the care that you so deserve. This is a benefit that everyone has, is hospice care.
Yeah.
And we treat everyone. It's not a, what is your insurance? We treat patients who unfortunately don't have insurance and who assume they can't receive care. So we are here to provide that care and education.
Dr. Richmond, can you also share with everyone the work that you do with education amongst the medical community? Because a lot of times when you have families who are receiving this information, the way in which it's brought to them is key, one. And two, it does help sometimes when people have someone that they feel they can relate to and who looks like them, who's knowledgeable with this information. And that's an area that Dr. Richmond can speak more to it, but that's an area where we're trying to close the gap, because there's the education amongst healthcare professionals, there's a lot of opportunity there. Dr. Richmond?
Thank you, Makia. Makia and I have partnered in so many presentations here in the DC area. We have a special love for Howard University Hospital, and we partnered with the Chief Medical Officer, Dr. Shelley McDonald Pinkett, to bring information to the medical students, residents, attending physicians, as well as to the psychosocial team. Having served as a medical director in the community at rehab facilities, nursing homes, assisted living facilities, we've also joined forces in bringing that information there. So we're looking for areas and avenues to bring this important information that may have been missed in a hospital setting, that oftentimes is missed in our own African-American predominant hospital settings, such as Howard University Hospital. And so the topics of conversation that we have a specific topic that we speak often about is culturosity, ethical decision-making, really diving into the ethical components as to why we are here today with the lack of knowledge when it comes to hospice care. And so as we continue to bring that information and more people hear the word VITAS and hear the words hospice care, it's not shunned, it's embraced. But there's still areas of education that we will continue to provide openly and honestly.
I have another question I would like to pose to you or Donna, but probably you in particular, Doctor. What type of policy recommendations would you offer to us as legislators? In 2018, we passed legislation in Tennessee around palliative care. And we have a council set up, X number of people, they meet to talk about this and, come up with ideas and recommendations to the legislature. They do a report back to us, every year. What kinds of things, what do you think about that, and have you seen that in other places? Or what kind of ideas could you give us that would help?
It's so nice. Representative Donna shared that with me. Donna said, we get all the information and then we got to get into the policy. Tell me what you want, Dr. Richmond. Tell me what it would look like for you.
Yeah.
But
Yeah.
Dr.
So
Campbell,
if I had,
this is Nobel women, honey. Once you give them,
Yeah.
you get them with the information, they can take it and run with it. So understand,
Representative,
I told her.
so if I had my way, and I'm taking my wish, how it would look for me is, I want that same panel, a hospice panel.
Oh,
I would
yes.
want that same panel, that hospice panel, where we create an arm in medical schools to have hospice and palliative care rounding, partnering with our organization. I would want us to collaborate with you all, creating a community outreach program where we are really, really highlighting local community churches and organizations. As Representative Scott stated, she has a group of, I would say, absolutely seniored women or seniored group of people that she'll be speaking with, having that opportunity, having that moment to speak about this beautiful platform, creating that particular arm where community money, community funds already implements that arm of information. I don't know if I'm explaining it properly,
You
but
are.
I definitely encourage the VITAS family to really engage and unmute your phones and assist me with this. But that's how it would look. What we're presenting to you right now, and it's so nice to be together, albeit it's virtually. But I feel the warmth and I feel the energy, but we need more opportunities like this. We need to expand beyond the presentation to sit down and create this platform of hospice advocacy. I would love to see hospice commercials. I would love to see this even in certain education systems, having that conversation, having that education about what is quote unquote end of life care. What does it look like? Can we create a curriculum around that? As opposed to having students, residents, practicing clinicians searching for this information. And thank goodness we're here to provide that information. But how do we create that connection, Representative? I want to do this more often, and in each and everyone's community and district.
So for me, if I could add on to that very quickly, we had the opportunity, Makia, Dr. Richmond, and I, to talk about what would some of those policy recommendations be. And correct me if I'm wrong, but medical schools are funded at the state level partly, right?
Yes.
So that having medical schools have a curriculum of cultural competency, I think, would be huge. Educating the young doctors that are coming out about the need for it and for it to be learned at that level. And then for doctors who are already established, making sure we have a program where they get their medical credits is something that could be offered as a medical credit. This cultural competency issue, I think, would be great.
Yeah, the CME, we developed, we currently, I just renewed my license in DC. The LGBTQ community, we have a competency, as Donna shared, in order to recertify, to receive or renew your license, you have to do this online or self-taught and take an exam at the end. But when I say the information, how it uncovered so much information for me, it was amazing. But would it have been something that I would have personally sought out? Probably not, and that's being honest. But having that there and making it a part of the curriculum in order to renew my license educated me. We are educated about medications, opioid medications. That too is mandatory in renewing our license. So that cultural competency arm of hospice and palliative care, generating CME credits for that, physicians would definitely take that on.
Okay. Thank you for that. Thank you for that. That's good information. Senator Agberry, did you have anything? Okay. She doesn't. All right. I just thought I'd ask our other board member if she had a comment or a question or two.
No, I
Anybody?
have a comment. I don't have a question, but I have a comment.
Okay, well, come on, Senator.
Sorry, I'll turn my camera on. I need to see myself first. Oh, shucks. I think I
You're
closed
probably
it.
looking good.
Hopefully, because
There
obviously
you
the
are.
camera's on now, so I don't know what I look like, but
You look
well, first
like,
of all,
you look
oh,
like
yeah.
Senator Agberry.
Forgot my hair was pulled up. First of all, guys, just thank you for this presentation. It is such a delicate issue in our communities, but such an important one. And I think what stood out was something you said earlier, where a lot of times families do not discuss death until it's already happened. And I know from personal experience, having an aunt who ended up in a palliative care situation, and the family did not handle it well. They viewed it as if she was giving up, when that was not the case at all. So I'm certainly thankful for the work you all do. And I know, also I heard earlier, you said Nobel women, we want our marching orders. So I'm looking forward to seeing how we can affect positive change within our respective states to change the narrative of this conversation. So thank you all. Happy I got to be on this. I was a little late because I had another event before this one, but certainly happy that we were able to connect this way. Thank you, President Kemper.
Thank you, Senator. And our co-chair for the Corporate Advisory Council is on, Ms. Yolanda Cash, and I know she knew about CLE, so she surely understand CME. So I'll give you an opportunity to say something. I know it's a lot of information, very informative, and from a legal perspective, you may, can offer some good intel for us.
No, I just can say Vitas, I think, started in Florida, if I recall.
Yes,
And,
yeah.
Just as so, I have a little history with them, and then state representative, then state senators, then Congresswoman Carrie Meek was very, very involved in making sure that Vitas and this type of care was available. So I just think it's so important having being the caregiver of a 90-year-old with dementia. It's something that I certainly have experienced firsthand. So it's just so important. And if there's an opportunity for you to present in Florida, because I don't think we've had this kind of conversation.
I am a Floridian. I'm from Miami, Florida.
Okay, I'm from
Yes.
Miami. I'm in Miami right now. So perhaps we
Yes.
can have a way to make sure that happens. It's just so very important. And for those families who've experienced it, I experienced it with my husband as well. And it's just so important what you're sharing. That's all I have.
Thank you, and thank you for that history lesson on Florida.
Oh,
Who was that was saying I'm from Florida too? Was that Karen? Oh, that was you. Okay, Dr. Richard. All right. Okay. All right. If you all have some closing remarks that you want to leave us with, we'd be grateful to hear from either you or Donna or both, or one of your operational managers.
I would just like to thank you all first for inviting us and letting us share this with you. I would piggyback on something that you said, Dr. Richmond, about cultural sensitivity and our education system. I think it needs to go back to kindergarten, not just to med school. But I do know recently med schools have really focused on some of that cultural training, but even so, they're not encompassing hospice and palliative and end of life care in that. They haven't made that leap. And among the obstacles that we've talked about, the medical community can be an obstacle as well. They don't start the conversation early enough either. They're uncomfortable with it, sometimes for their own cultural or religious or personal feelings. And so they don't really pass on that information either. So getting the word out and educating it's just an enormous job. So but these kinds of grassroots ways are the best way, I think, to make it happen. So thank you so much. And Ms. Smith and Ms. Miner, thank you for those downloads. I have those links. I've downloaded them and I look forward to reading both of them. So thank you for sending them. I was hoping to say hello to Delegate Aird because I'm sitting in Richmond and she's not far away, but I think she had to step away.
We will make sure that she knows that.
Great.
Donna, any closing remarks or anyone else?
Well, I would just want to thank Vitas and Makia and Dr. Richmond. I reached out to them and I was like, look, I have this opportunity. I think you guys would be great for it. And, you know, I always welcome the opportunity to get together with the Nobel family. And I'm looking forward to talking to Vitas more about joining our corporate advisory board. So.
Yeah.
Thank you all.
Wonderful.
Well, thank you all again for being here. Thanks to everyone who attended the session and all of those who are eventually going to be watching on YouTube and Facebook. This is some powerful information that we can take back to our communities and make sure that they're getting the most current, timely information, the things that can help empower their families when they're taking care of their loved ones at the end of life. So I learned a lot. I'm sure everybody on here learned a lot. And it appears to me that we're going to start implementing some of these things in our communities and inviting both Compassion Choices and Vitas to join us in that effort. So thank you again for being here, and everybody have a great rest of your evening.
Thank you all so much.
Thank you. Thank you, Donna. Thank you, everyone.
Good night.
We have everybody's contact information, and you guys can reach out to us at any time.
Thank you all so much. Good night.
Bye, everybody.
Bye-bye.
Good night.
Good night.